First of all, let me thank all the organizing committee, Dr. Abdullah, Dr. Fawaz, and all the organizing for the nice invitation. I really enjoyed that meeting, and I did learn a lot. Now, can we have it? Okay. So I'm presenting a case of 62-year-old gentleman with recurrent episode of chest pain for more than 2 days. He's hypertensive, diabetic. His ECG showed ST elevation in V1 to V4 and AV1 and AVL, and with reciprocal changes in the inferior lead. His blood pressure was on the borderline 90/60 with reasonable O2 sat. The quick echo showed this ejection fraction of 40% with anterior hypokinesis, and the plan was to do primary PCI. So this is a fixed picture. Is there any laser pointer or? Anyway. So, but this is the angiogram. You see that there is proximal LAD, and on the other one, the other view, you see apart from the proximal LAD, there is thrombus burden. So quickly we did the guiding catheter and a quick aspiration, and after the aspiration, we get better flow. And the patient chest pain subsided. So the plan was to finish with stenting. So, but we decided to do Ivus to that lesion, and the lesion showed significant plaque burden in the LAD from the mid segment, and the reference vessel diameter was 3.6 millimeter. And just if you go pulling back, significant plaque burden, and the burden reaching the ostium of the LAD. And if we continue until we enter the left main has minor plaque burden. There is no significant stenosis and good left main with the diameter of 4.5. So the plan was this lesion length was around 42 millimeter. So the plan was to stent this area. We did not have 42 millimeters, so the plan was to put to stent. So pre-dilated, and we put the stent in from the proximal LAD to the mid segment, and this stent was 3.5 by 24 millimeter DES, and did the post-dilation with the 3.5 at the distal part of stent and 4 millimeter NC balloon at the proximal part of the stent. Then we put the other stent from the left main to the proximal LAD with a little bit of overlap, and this stent was 4 millimeter by 18. And did also pot or post dilation in the left main. And you see this is the difference. This is before we put the first stent, and this is the after the stenting, and it did show reasonable result. So whether to do any further, we put a wire in the circumflex and decided to do Ivus since we are working on the left main. So this is the Ivus pulled back from the proximal LAD back to the left main, and we see well-opposed stent in the LAD. So just to, for not to, let me get some more time. So this is the pullback from the LAD to the left main, and you see here the stent is not well opposed in the left main, and there is stent deformity in some part of the left main. So just to complete, we put the wire through the circumflex and did the pullback from the circumflex, and you see the circumflex has no plaque burden, and we'll see now the thrust across the ostium of the circumflex, and we entered the left main. When we were pulling the catheter, we did notice some resistance, and that's what we got the catheter, and you see the catheter here we got, it's a broken catheter, a broken Ivus catheter. Just going back now to the fluoro, and you see that we see this is the catheter end, and let me put that on the cine, and you see that here, you see that dot, and on the other one also you see that this is just pure fluoro, and you see the dot, and this is also, after reviewing the Ivus, you see that here at around 11, you see that area. This is the tip of the broken catheter that we were able to catch it. So this is what happened now. Let me stop here and ask for some opinion before we go. So this is a fixed picture just explaining everything. Now,
just before we go any further, so this is Boston Scientific, I'm assuming, right?
sorry?
The Ivus catheter type is Boston Scientific, that's correct. And you faced the resistance when you were going in or on the way out?
No, just on the way out.
On the way out.
From
and then
the circumflex.
You realized this
Yeah.
later on after you built everything?
Yes.
Okay. So you have a wire in place now, still?
Well, I'll tell you what happened.
You still have a wire beside?
Where? In the circumflex?
The wire is still not pulled. In the circumflex you have a wire? Or
No,
just the LED?
No, unfortunately, when we pulling that, the wire came out from the circumflex.
Okay, sure. So just to clarify, the dots you shown us in the LED, right?
No, this is the dot in the circumflex.
Okay, in the middle one, this is the LED or the LCX?
No, this is and that's a fluoro. That's an
Okay.
AP cranial that's overlapping. This is the stent in the LED, but
So we
this
have-
is the dot. This is the dot that I show you in the
Yes.
caudal view. This is the dot in the
Sure,
circumflex.
so clear.
But this-
So you have a broken segment of your catheters
Yes.
in the LCX
In the LCX.
with no wires across it
Yeah.
or beside it.
Yeah.
Thank you.
Okay.
You want to comment?
I think this happened after you try to pull it out from the left circumflex,
Yes.
because some struts are there in the left main,
Yeah.
and you didn't land in the ostial LAD because there was
Sorry.
disease extending to the distal left main.
Yeah, we did the Ivus pullback from the LAD to the left main, and it was, we did document that there is malopposed and probably deformed stem that need further work up from
Okay, and you know that there is a struts in the left main, in the distal left main.
Now, after we crossed to the circ,
Okay.
and we did the pullback from the circ, that there is no lesion in the circ, but there is a strut across that we see, and then we got this problem, broken catheter. So we lost, sorry, Sophia.
There is a stent in the left main or no?
There is stent of the left
And
main.
you crossed through the struts of this stent?
Yeah.
But
I
you
showed you-
didn't dilate the stratus from left main
No.
to CX.
Well, I showed you I did pot in the
Yes,
left main.
but you did not open the stratus. You went
No,
with
no,
the
no,
Ivus
just-
catheter
just
through
for-
the normal
yeah,
stratus without dilating.
Yeah, just I went from the stent to the circ and did the Ivus. Yeah. Yes.
Just, do you have any comments, or we can ask if the audience has any?
No, we should, let's go on.
Okay, so we lost the, while we pulling, we lost the wire from the circumflex. The LAD wire remained in place, but no balloon now going through from the left main to the LAD. Probably with that, because we moved the stent and peeled the stent from the left main, it was already deformed. So we were unable to cross from the left main to the LAD. So we were able to cross behind the left main, behind the stent, because the stent has moved, and enter the circumflex. The plan was to dilate this area and try to snare this piece, but no snare could go behind the stent. So we switched to the plan B, which is crushing now the left main stent and putting a new stent from the left main to the circumflex, cover this broken catheter and exclude that from the circulation. This is a diaphragm, and I hope that everybody can understand that I'm not going to go through the diaphragm. So that's we went to the circumflex behind the stent and dilated the area. and crushed the stent, and then dilated through the crushed stent, went to the LAD and did kissing. And then we put stent. Now here you see the stent from the left main to the circumflex. That's, I put it in 3 views to document the position. Okay. And with that, we did kissing again and pot to the proximal, and this is the final angiogram. And this is in the caudal view, this is in epicranial view, and this is at the spider view. So after that, we did the full Ivus pullback from the LAD to the left main, and you see here that we get a well-opposed stent in the LAD, and with a very good area in the distal and the mid and the ostial. So no further workup. And then we have pullback from the LAD to the left main. And we see that 2 layers of stent, and there is some a change in the shape, but the diameter was adequate. So I don't think I had to do further workup. And now this is the pullback from the circumflex to the left main, and you see now the stent also on the circumflex is well opposed with good cross-section area. And this is the last part from we got from the circumflex to the left main, and also it's clean. So that's what happened. So what I can conclude, the stent was malopposed in the distal left main, and there were thrust across the left circumflex. Interrogation of this side branch with Ivus for the circumflex should have been attempted after repot, I think. That would have prevented this complication. And the Ivus catheter fracture happened at the interface between the guide wire and this exit port. Okay, thank you very much. I'll be happy to accept any question.
Sure. Thank you, Dr. Walid. I have a question with regard to your approach here.
Yes.
Why didn't you consider going through the struts, opening it, and doing keylot, for example, instead of trying to crush a stent in the left main, adding more layers at this area that is very important?
Yeah, I told you this is plan B, but I couldn't go through the stent. Although the wire coming from the left main to the LAD, I couldn't go with the tiny balloon through that stent to open it up. I think just when we pulled, the stent already deformed. It's not well opposed. When we pulled also, it was really peeled from the left main and changed the shape.
Sure. So you couldn't get any balloon across your LAD left main
Although
wire.
the wire was still present from the left main to the LAD.
Any comments, Dr. Wal? You want to, any comments from
Yes, that's a great case, Dr. Walid, and thanks for sharing this complication. But I think that the lesson to be learned here from our practice, because it happened with us actually in a very worse outcome.
This happened as a planned left main intervention.
It happened with us. The stent was prolapsed into the left main. The stent from CX was prolapsed because of the Ivus catheter. But I think that if you're going to cross with the Ivus or OST catheter through the left main, it's better to open the stratus from the left main. This is the take-home message, I think. We need
Point well taken.
Okay, so we have to move, guys, to the next, then we'll have more comments. Thank you very much.